Most of us realize that the ability to control pain is an important protective mechanism for our bodies.
Even so, when we experience pain, acute or chronic, we generally want to control it or get rid of it entirely.
On this week's Health Talk, we'll talk with a pain management specialist about pain and new options for treatment.
So please join us for a really interesting show on a topic that affects almost everyone.
We're up next.
Hi, I'm Dr. Eric Mazer.
And I'm Dr. Andrea Peterson. Today we're talking about pain management. Joining us is Dr. Puja Shah. Dr. Shah is an anesthesiologist and a pain management specialist with Norwalk Hospital.
Puja, thanks for joining us. First time on the show.
Welcome.
Yeah, thank you for having me.
And this is such a prevalent, important topic, pain. And you're a pain management specialist. So maybe you could tell us a little bit about acute and chronic pain and how they differ and how our approaches begin to differ. We'll take it from there.
Okay, so there's a lot of talk about pain in the media, and so people who are even non-medical seem to have a good amount of information out there, and so it would be good for me to kind of start from the basics. Acute pain is simplified stubbing the toe. You're walking out, having a normal day, and all of a sudden you feel an acute pang of pain or breaking a limb. That's usually treated with medications like opioids that we hear about, oxycodone, strong pain medications to get that episode underway.
Now that pain is often quite severe, but there's a time limitation to it, and there's a clear anatomic cause from it. You break your arm, you stub your toe,
Exactly.
You bang your head, you get a bump. I mean, there's something that your body's telling you. It's telling you it has been hurt, it's been injured, and there's very strong signal to try to avoid those kinds of things.
Right, and like you said, it's a protective mechanism. If we didn't have those mechanisms in place, we would actually hurt our bodies even more. It's kind of like when our hand goes back from the stove very quickly. Our body has a way of protecting it, or else we would have a third-degree burn every time we were cooking. So like you mentioned, acute pain is very defined, and so that in many ways can be easier to treat, and that we know why it's there and it does have a boundary. Going into chronic pain means that it's pain that has lasted for 6 months or greater. And as time goes on, the actual root cause can be very vague. What started off as a car accident or a broken limb can then turn into a web of pain symptoms, including burning, numbness, that can become very difficult to differentiate.
Now, how does that happen? Because as you said, it really, and without being too
Medical.
physiologic or medical, but it's pain that's going on where there's no injury anymore, and that's hard to understand.
So the way I like to explain it to people is that it's as though the body has a little bit of a short circuit. And so we have to remember that every person deals with pain differently, and it's not necessarily all psychological. Our bodies are different as well. And so after the accident or the burn or whatever you may have, not all the neurons and the nerves in the body are back to 100% normal. So many of them can short circuit. And so even when you're not turning the light switch on and off, you still have that spaz of electricity. And so you can imagine over 6 months, 6 years, that can be very troublesome. And so then, as the patient becomes even more prone to that, it can really affect the mood, it can make people depressed. And so I truly believe that the longer it goes on, the cycle can get worse because, as we all know, when our mood and stress levels are not the best, then we're also more prone to feeling more pain and having more symptoms affect us.
I think that's really important because people who do suffer from chronic pain, it really can affect all aspects of their lives.
Yes. Actually, interestingly, some of the medications we use nowadays are actually antidepressants, and some of which were not really great antidepressants in the psychiatric world, but do have a role in treating pain because our body is made of nerves all over from head to toe, and so if we're treating a nerve that's going down the leg, such as sciatic, it can also affect the nerves that are in our brain. And so some people do really well with the dual purpose, with the mood and the pain, and it's almost harder to say what came first. Were they kind of in a pretty crummy mood all the time, and so they were having more pain, but now that their pain is dissipating, their mood is also better, so it could be a win-win.
Maybe we can also take a step back a little bit. You talked about there being a difference between acute and chronic pain, but not all pains are alike. Isn't that true? So there's nerve pain, there's soft tissue pain,
right,
and they may have different mechanisms.
Right. So the most classic pain, like I said before, stubbing the toe, that is like soft tissue. When we get a bruise, it's soft tissue. It's everything around the bones. And of course, there's bone pain from trauma when you break a bone. I find that the most difficult pain to treat is nerve pain. And so when we get more into the chronic pains, that's when the nerves are firing, even without the body telling them to. That we're not next to that stove anymore and having our hand come back, but yet our body still feels. And some of it may be a protective mechanism. Perhaps the body is saying, you know, I'm not healed completely, so I'm still trying to show you that. So protect me. Don't throw that leg into the marathon race tomorrow, or, you know, be careful when you're out in the snow.
But as you said, I've recently had a bout of sciatica
Okay.
myself from a ruptured disc, and there was something about that pain that was more unpleasant. That is classic nerve pain. That was more unpleasant than any pain I've ever had in my life. You know, more than I've had broken bones.
Right.
I've had, you know, those kind of, but they're qualitatively, which depending on which nerve is firing,
Yes.
they can give you a qualitatively different experience with
Yes.
pain.
And I think it's been shown in the literature and just in normal life that when we can't explain the reason why something is happening, it bothers us to such a greater extent. And we can think about this in our normal lives, just with like emotional issues. But when it comes to pain, a lot of my patients will say, but why is it happening? I mean, I look fine. I have a ruptured disc, but I don't feel anything different. Some of these people are even in great shape, but they can't really make sense or actually understand why this is firing. And so that makes it even more cumbersome to deal with.
So it sounds like especially treating chronic pain takes more than one way of approaching it. You really have to help the whole person.
You do have to help the whole person. And we also have to realize that some people are having chronic pain from true disorders, such as cancer pain, a bone that never healed properly. But regardless of the cause, if you're dealing with chronic pain, it's going to affect your entire life, from when you wake up in the morning to get coffee to when you're going to sleep. It affects your sleep, it affects your quality of life, and most importantly, affects your mood. And without a great mood, it's very difficult to heal from anything. So I think that I would like to hope most pain doctors in today's generation really look at the patient as a whole and not just the actual body part.
And I think, yeah, it's important to re-emphasize pain is a subjective experience.
Yes.
It's happening in your head.
Yes.
So it doesn't mean that you're crazy.
No.
You know, if you break your arm, the pain is here. The arm hurts, but
Right.
it's an experience that
Right.
you have. If I anesthetize, you're not in pain anymore.
Right.
If I put you to sleep. So it's a conscious experience. So when people say, is the pain in my head or is it not in my head, that almost isn't the issue anymore if someone's
Right.
having chronic pain, because you are experiencing that pain.
Right.
So
and I think a lot of my job does involve the psychology. I like to help patients accept it, that it's not you and it's not your fault. And perhaps maybe if two people went through the same problem, you would be suffering more, but that's just the way your body is. So instead of focusing on that, we can start looking at treatments. And I think that really gets people over this hurdle, or if they're plateaued, and then they can actually start seeing some progress. The self-acceptance and understanding that the psychology behind it is a huge component.
Maybe you can talk to us a little bit about ways of managing pain. You know, we talked about treating mood and the importance of exercise. When it comes to medications, for example,
Okay.
what's in your toolbox?
So we all know what opioids are because fortunately or unfortunately the media has made us very aware. So those are the medications we think about when we go to the dentist, after a root canal, after a major surgery. They're the most potent drugs we have, and they mimic the actual pain relieving elements that we have in our own body. So it's a chemical version of the body's own pain relieving elements. After that, we have some in-between medications, nerve pain medications. You'll see on TV, Neurontin, Lyrica. These help a lot of that chronic pain when the nerves are still firing, although we do not no longer have a root cause or actually an alarm system for that in place. There's also agents like antidepressants, Cymbalta. Their commercial is pain hurts, depression hurts. And I really like that commercial because it's been shown that people who are depressed, many of them, especially women, can manifest it as pain. And so if you're an astute doctor, you won't just brush them off and say, oh, she has a headache. You may realize that this is the way that this patient is actually showing us that something inside is just not right. There might be a chemical imbalance. And then we can go down to the more basic medications, the Advils, the naproxens, the Tylenols. And I always like to emphasize that they do have a role. As much as we don't think that they're as strong as some of the aforementioned medications, if your normal pain after a ski accident is a 10 out of 10, the Tylenol can get you down to an 8. So it's much easier to go down from an 8 than from a 10. So they do have a role in the background, and everything should be used in conjunction and, of course, under the supervision of someone.
So when you see a patient who comes to you with chronic pain, take us through the process. What do you do?
Well, first of all, it's important to know why. And each patient isn't going to come up to me and say, this is why I have pain. But if there is a systemic disorder like rheumatoid arthritis, a cancer, an ongoing systemic problem, they're usually in one category. And luckily, they're also being treated by other physicians that I can consult with. Then we have a whole slew of patients that maybe had an accident in the 1950s and continue to have a sciatic-like pain every single day for the rest of their life. And often these patients are a little more difficult to heal and take care of because nothing in their medical profile really tells us why, but of course we're going to do our best to listen to what they're feeling. So these days I like to take a look at their entire medication profile, especially focusing on if there's any psychiatric medications involved.
And when you say psychiatric, again, that doesn't mean they're crazy. It doesn't mean the pain is in their head.
It means that they may have a concomitant condition that they're working with a psychiatrist for. Whether that has to do with the pain or not, it may not even matter because they're getting treated for something that may even be alleviated if I do a good job treating their pain too. The other reason it's important to look at those medications is that a lot of medications like Xanax, these Valiums can affect the body in similar ways that pain medication can. They can both cause people to become over, sleepy, dizzy. So it's also from a health standpoint, I would never want to prescribe someone something without knowing their entire profile. Mixing two drugs that can possibly be dangerous is obviously different than just having one. And then I like to go through the list of symptoms. Before we go into imaging, I need to talk to the person as a whole, like we are. How does it feel? When is your pain the worst? What makes it better? Do you notice that when you're in a particularly good mood, your pain is better? Is sitting worse? Is standing worse? And each of these things hints to me maybe the part of the body. For example, with a ruptured disc, some people are worse with sitting. Some people are better actually after walking, which may not make sense. So different parts of the spine manifest in different ways, and that's how we can target the part of the back that is really being affected.
And we have just 1 minute left, but a question that's really in the press today is somebody with non-malignant, they don't have cancer, but they have chronic pain. Are opioids still part of that armamentarium? Are some people appropriate to be receiving opioids in that setting?
Yes, but I will say that often doctors will feel that a lot of other options have to be exhausted. Or what are the risks and benefits? So if I have a patient who's 80 years old and she's on 1 Percocet a day, it allows her to go play bingo with Betty or get to Stop and Shop, and she has no other medications that interact, and she's not having any side effects, I say, why not? It gives her a good quality of life, and it's allowing her to get to the places she needs to. But with that said, that same rule doesn't apply for everyone. If someone is also, taking other medications that may interact or also has a history of any sort of abuse, then my job is going to be a little more difficult and I'll have to hone in a little more on that sort of situation. So it's very case by case.
Incredibly complicated.
Very
complicated.
That's why doctors are sending all these patients to you.
Yeah.
Because it's so hard. Unfortunately, we've run out of time. We'd like to thank our guest, Dr. Puja Shah, for joining us on Health Talk today.
And thank you for watching. Remember, please send us your questions and comments to healthtalk@wchn.org.
Stay well and pain-free.